The issue of autologous stem cell transplantation in multiple myeloma is becoming more and more important these days. And it looks like that despite the advent of many novel agents, many data are still in favor of performing auto transplant frontline in newly diagnosed multiple myeloma patients who are fit and eligible. And actually, this is very interesting because it suggests that if you want to improve multiple myeloma patients' outcome, it's likely that you will have to join forces between the new drugs and auto transplant. Having said this, actually there is a lot of heterogeneity when it comes to performing auto transplant all around the globe. When we consider Europe, for example, access to an auto transplant center is relatively easy, and I think auto transplant is widely used and very popular, especially that one must admit these days that auto transplant is becoming more and more cost effective, allowing for long duration of progression-free survival. And this has been recently shown through the IFM 2009 randomized trial, but also with the European Myeloma Network trial. Of course, age and comorbidities are a matter of concern, and age limit can vary from one place to another. However, we can see that the age limit keeps on increasing. And in this meeting at ASCT 2017, there is a presentation, unbelievable, about auto transplant above the age of 75, which is quite amazing, showing similar results to younger population. So in Europe, I think auto transplant is well established. In the US, in North America, maybe the landscape is slightly different, and the use of auto is maybe less popular in some places or some centers because many patients have also access to all of these novel combinations. And it may be actually interesting to ask the question, we don't have the answer actually, whether very robust quadruplet or triplet combination allowing for deep negative MRD, minimal residual disease, may allow in some patients to avoid a transplant and its relevant consequent toxicities. So the picture is heterogeneous. It's always a moving target. Of course, I didn't mention the rest of the word where sometimes it is access to a transplant center which may be problematic. So in summary, I think auto transplant is really a standard of care in the majority of patients. I do believe that it should be offered in combination with all the new drugs, in induction, transplant, but also post-transplant therapy should be offered. Maybe, but we need to wait for the prospective controlled trials, the use of some very potent novel agent such as daratumumab and or carfilzomib in combination with IMiD, for example, may allow in a subgroup of patients for long-lasting deep negative MRD, and in that case we may question the use of transplant. But for the moment, I think it's a very highly effective therapy that allows actually also, and this is important for our patient, for some treatment-free interval. And I think this is really very important for the quality of life of our patients.